Trends in the management of open fractures. If the fracture communicates with the outside environment, then it is called an open fracture. Tibia and phalanx are most commonly affected. High energy trauma is usual culprit. Contamination with the dirt and debris and devitalization of the soft tissues increase the risk of infection and other complications. Assessment of the soft tissue damage is very important. The size and nature of the external wound may not reflect the damage to the deeper structures. Soft tissue wound in proximity to fracture should be treated as an open fracture until proven otherwise. Cultures are not recommended either before or after debridement. Organisms that are found to be contaminating an open fracture on presentation don't represent the microbes that will eventually cause infection. Most infections at the sites of open fractures are caused by nosocomial bacteria. Most open fracture infections are caused by gram-negative rods and gram-positive staphylococci. Classification system of open fractures, that is popularly followed as Gestilo classification. There are three types are there. Type 1 is wound is less than 1 centimeter, minimal contamination, minimal comminution, and minimum soft tissue damage. Infection rate is 0 to 2%. Type 2 wound is more than 1 centimeter, moderate soft tissue damage, minimum soft preosteal stripping. Infection rate is 2 to 5%. Type 3A, severe soft tissue damage, substantial contamination, soft tissue coverage adequate. Infection rate is 5 to 10%. Type 3B, severe soft tissue damage, substantial contamination, coverage is inadequate. Infection rate is 10 to 50%. Type 3C, arterial injury requiring repair, the infection rate is 25 to 50%. But ideally, you have to do classification on the operation table after opening the open fracture. Coming to the compromising comorbidities. Significant predictors of infection in the multivariate analysis are medical and immunocompromising factors, age of 80 years or more, current nicotine use or diabetes, malignant disease, pulmonary insufficiency, systemic immunodeficiency. Coming to the treatment, antibiotics should be administered to patient with an open fracture as soon as possible to reduce the risk of infection. A patient with an open fracture should be taken to the operating room on the urgent basis. Patients receiving the first generation cephalosporin found to have lower infection rate than those receiving penicillin and streptomycin. There is no clear guidelines regarding combination, dose, duration of antibiotics. Timing of operation. Operative treatment within 5 hours was associated with a lower rate of infection. Administration of antibiotics after an open fracture reduces the risk of infection by 59%. Coming to the evidence-based recommendation for treatment of open fractures. Antibiotics, there is a good evidence for giving an IV antibiotics. Local therapy, fair evidence is there. Timing of operative treatment, it should be urgent. For that, there is a fair evidence is there. Within 6 hours, there is a poor quality evidence. Irrigation, high pressure pulsatile lavas, there is insufficient or conflicting evidence for the high pressure pulsatile lavas. Adding antibiotics or some other antiseptics, there is an insufficient evidence is there. Fixation of open fractures, femur, intramedullary nailing, there is a fair evidence is there. Tibia, internal fixation, there is a fair evidence is there. Intramedullary nailing, there is a fair evidence. Reaming or unreaming, there is a insufficient or conflicting evidence is there. Wound coverage, primary closure, there is a fair evidence is there in the literature. Vacuum assisted closure, there is insufficient or conflicting evidence. Adjunctive therapies, there is a fair to poor quality evidence is there. Modality is not recommended is the wound culture. For that, there is a fair evidence.